Dr. Ray here from Vet Triage. We are continuing through this May 2022 edition of Veterinary Surgery, and we are talking about dogs with elbow surgery. The medial epicondylar fissure fracture as a complication of transcondylar screw placement for the treatment of humeral intracondylar fissure. This study comes out of a specialty hospital in the United Kingdom. The objective is to report the incidence of medial epicondylar fissure fracture after medial to lateral transcondylar screw placement in dogs with humeral intracondylar fissure and to identify risk factors. Results found that the medial epicondylar fissure fracture occurred in 11.4% following medial to lateral transcondylar screw placement. And so I'm trying to show you here, it's very difficult to see on the radiographs, but trying to show here with this arrow the fissure here. It's very difficult to see. A larger relative screw size was found to increase the risk of the medial epicondylar fissure fracture. 15 additional complications were identified in 13 out of 80 elbows at 6 weeks postoperatively, median. Screw loosening was most frequent, 9 cases, and was the only complication in dogs with the fissure fracture, just 3. The fissure fracture tended to increase the risk of perioperative screw loosening. So the conclusion was that medial epicondylar fissure fracture occurred in 10 out of 88 elbows treated for humeral intracondylar fissure and was more common in elbows treated with a larger screw size relative to the height of the condyle. Clinical significance was placing transcondylar screws with a diameter inferior to 41% of the height of the condyle is recommended to avoid this. Medial epicondylar fissure fracture has a low clinical significance, although its effect on long-term outcome is unknown. Introduction. The humeral intracondylar fissure may be diagnosed as an incidental finding or as an infrequent cause of thoracic limb lameness and elbow discomfort in dogs, especially spaniel breeds. The pathogenesis is unclear. Initially proposed as incomplete fractures of the humeral condyle, they were subsequently attributed to a failure of normal osseous fusion. Humeral intracondylar fissures were termed incomplete ossification of the humeral condyle due to their identical location to the cartilaginous plate that forms between the two ossification centers of the humeral condyle in growing dogs. However, most recent evidence has supported that these lesions may be stress-induced. Conservative treat, which is weird though, because we usually see these in spaniels, so I just don't, I'm not sure I buy it that I'm sure stress-induced plays a role, but it seems weird that spaniels that we typically see this with. Conservative treatment of the humeral intracondylar fissures results in subsequent fractures in 3 out of 12 dogs that had been identified as having this lesion during treatment of a contralateral fracture. Similarly, humeral intracondylar fissures diagnosed as an incidental finding in 30 dogs resulted in fracture in 18% of dogs. 6% became lame and required surgical treatment. Such treatment relies on a transcondylar screw placed from a lateral to medial approach to the humeral condyle. However, screws are prone to fatigue failure at the fissure, with rates varying between 0% and 10%. The failure has been attributed to inconsistent healing of the humeral intracondylar fissure, maintaining intracondylar instability and stress on the screw. Placement of a larger screw across the humeral condyle is typically recommended to prevent implant failure. And so that's what we're showing here is the transcondylar screw being placed. The authors have recently identified a novel intraoperative complication following placement of transcondylar screws, visible as a radiolucent line or a fissure fracture on the medial epicondyle or non-articular portion of the medial humeral condyle, which is what I'm trying to show here. Materials and methods. These cases were between 2010 and 2019. This X-ray I'm going to show you represents medial epicondylar fissure fracture locations on a lateral radiograph, including an example of angle calculation relative to the long axis of the humerus in white lines. So this is the picture here showing that. The presence of absence of this fissure fracture, including location on the condyle if present, described as an angle relative to the humeral shaft centered on the screw head. That's in that picture that I just showed you. Complications were defined as major, meaning requiring medical or surgical treatment to resolve, or minor, meaning no treatment was needed. Surgery, the cases were covered with cefuroxime. They used stainless steel 316 LVM low carbon vacuum melt surgical stainless steel transcondylar screws with a 4.5 millimeter shaft screw, 2.7 millimeter slash 3.5 millimeter slash 4.5 millimeter cortical screws placed using fluoroscopy, medial or lateral approach to the humeral condyle. The countersink was performed manually following drilling, where screws were placed in lag fashion. Drill stops were applied to the drill bit to enable accurate drilling of the glide hole. That's how they're able to get the screw head beneath the surface of the bone there, so it's not sticking out. Results found the most common breed were English Springer Spaniels, 65%, Cocker Spaniels, 20%, and then others. Dogs weighed a mean of 18.9 kilograms, median age 36 months. Complete humeral intracondylar fissures in 78% of elbows, equally distributed between left and right. The most frequent transcondylar screw was 4.5 millimeter shaft screw. 85 screws were placed via medial approach. That's 96.6% of cases. The degree of countersinking was less than 50% of the screw head and 61.4% of elbows. The median screw angle was negative 3.5 degrees. Median screw size to condylar height ratio was 40.2%. So that's what they get the 41% cutoff. Arthroscopic treatment of medial cornoid process disease was performed prior to transcondylar screw placement in 25% of elbows. Post-op antibiotics were given in 92% of cases. In regard to the medial epicondylar fissure fracture, or I'm just calling it fissure fracture, it was documented in 11.4% of elbows during placement of a 4.5 millimeter shaft screw via medial approach. The fissure fractures were predominantly located between 169 and 270 degrees. Risk factors: lower body weight was associated with increased risk of the fissure fracture. The mean weight was 16.3 kilograms. Those that did not have the fissure fracture were 19.2 kilograms. Screw size to condylar height ratio was also associated with an increased risk of fissure fracture. Screw size to condylar height ratio was the most significant of these explanatory variables associated with increased risk of fissure fracture development. Complications: most were perioperative, meaning in 0 to 3 months. The most frequent complication was screw loosening, occurring usually in the absence of infection at a median of 6 weeks after surgery. Infection was consistently excluded by cytological examination of synovial fluid in conjunction with clinical signs and radiographs. Screw loosening was the only complication seen in dogs with fissure fracture. The presence of fissure fracture was not found to increase the risk of subsequent perioperative screw loosening. Deep surgical site infection occurred in 4 elbows, which is 5%, all without fissure fractures. Septic arthritis, meaning lameness, inflammation, joint effusion, discharge, was in 2 cases. Osteolytis, neutrophilic arthritis, positive culture of synovial fluid, implants or discharge fluid. 2 dogs without fissure fracture had seromas at 2.5%. Screw loosening was treated surgically in some dogs. Additional perioperative complications per elbow were defined as minor, meaning 1.25%, major surgical 8.75%, major medical 1.25%. The rate of perioperative complications was 22.4%, of which 12.5% were major, so 11.25% surgical, 1.25% medical, 9.9% were minor. Overall, complications were documented in 24.9% of elbows, 15% were major, 9.9% minor. Discussion. This is the first study to report fissure fracture as an intraoperative complication during the surgical treatment of humeral intracondylar fissures, documented in 11.4% of elbows. Increasing the size of the transcondylar screw relative to the dimensions of the humeral condyle increased the risk of fissure fracture. The lower value of the interquartile range of screw size to condylar height ratio prompts us to recommend the placement of screws that do not exceed 41% of the minimum humeral condylar diameter. Increasing screw size reduces the rim of bone around the screw head and may predispose to fissure fracture as the screw is tightened. A screw size of 30 to 50% of the isthmus of the humeral condyle, and so that would be the central portion here, has been recommended previously to treat this condition, although this range is based on clinical experience. Another study suggested that a humeral condylar diameter of greater or equal to 10 millimeters can safely accommodate a 4.5 millimeter transcondylar screw, equivalent to a 45% relative screw size. Most fissure fractures in this study was associated with a screw size exceeding 41% of the condylar height. The second factor is maybe the amount of torque applied to tightening the screw. You can use torque limiters to help with this. Medial epicondylar fissure fractures originate at the screw head, prompting the authors to speculate that any lagged screw with a domed head, including standard cortical screws, may be at risk of causing fissure fracture when the screw is tightened against the medial epicondyle. Cases identified perioperatively, including those detected as an audible crack as the screw was tightened and or fluoroscopic during surgery and or immediately postoperatively on radiographs. Complications occurred in 24.9% of elbows, 15% were major, 9.9% minor, and these were predominantly perioperative complications at 22.4%. Studies assessing complications after lateral placement of a transcondylar screw using criteria defined by another study reported rates of 59.5%, and another study 69%, another study 46.2% with a medial approach and a cannulated drill system. Reported complications in 16.7% of elbows, another study 19.4% of elbows treated with medial lateral screw placement. Screw loosening was a frequent complication, most occurring in 9 cases, most instances 8 occurring without infection. The presence of fissure fracture tends to increase the risk of further perioperative complications. In this study, no dogs had evidence of osseous infilling at the fissure fracture at 6 weeks postoperatively, although radiographic evidence of healing was seen at 14 and 17 weeks. In conclusion, the fissure fracture occurred in 10 out of 88 elbows, most common in elbows treated with a larger screw relative to the height of the condyle. Surgeons should be aware of this risk, especially if the screw size to condylar height ratio is greater than 41%. The clinical significance appears to be low, and most cases heal uneventfully, but long-term is unknown. So, this is a solid study, important for surgeons especially who deal with this. And it's only 74 dogs, 88 elbows, so you kind of want more than that. And it is retrospective, so there's weaknesses there. But for surgeons who do operate these, this is another factor to consider now, is that 41% cutoff point. All right, we'll see you guys in the next video. Take care.